Professor Ariel Ortiz-Lagardere, streaming live from the International Bariatric Club studios. And I am delighted to announce that today is the 135th IBC University of Oxford Surgery webinar. The IBC University of Oxford webinar series is a collaboration between the IBC and the NUPIL, Department of Surgical Sciences, University of Oxford. The aim of the webinars is to provide free and first-class surgical education globally to improve patient care. In addition, the University of Oxford has allocated September 15th through the 17th of 2026 as the dates for the 7th IBC University of Oxford World Congress being held at the Examination Schools, University of Oxford. For more information, go to ibcclub.org. The theme of today's webinar, which will be streamed via the IBC website, the IBC TV YouTube channel, and IBC Facebook page, is Redefining Enhanced Recovery, Surgery Strategies, and Bariatric Surgery, and will feature experts from the Czech Republic, Spain, Egypt, Brazil, the United States, and Italy and Colombia. We would like to thank our global education partners for the 2026 IBC University of Oxford webinar series, which are Bariatric News, the International Obesity Society, the Upper Gastrointestinal Surgical Society, Laparoscopic Surge, Bariatric Channel, the Robotic Global Surgical Society, the Operating Room Global Foundation, and the Gulf Obesity Surgical Society. We would also like to thank our platinum sponsors, Johnson & Johnson MedTech, Reach Surgical, X & Y Medical. Our gold sponsors, Medtronic, McConvey, ConMed, Karl Storz, Standard Bariatric Stellaflex, USGI Medicals, GI Windows. Our silver sponsors, Easy Search Medical Arabian Corps. Our bronze sponsors, Intuitive. The chair of today's webinar is Dr. Karin Dolezalova Kormanova. Dr. Dolezalova is Bariatric and Metabolic Surgeon and head of the Bariatric and Metabolic Surgery Department, University Hospital Královské Vinohrady, Prague, Czech Republic. Previously head surgeon at OB Clinic, Prague, Czech Republic, and I will now ask Dr. Dolezalova to introduce our esteemed moderators.
Hi. Nice to be in this nice and interesting topic, and I would like to introduce the other moderators that is coming from Brazil, Guilhermino Nogueira, who is a general and bariatric and robotic surgeon, founder and medical director, Instituto Nogueira in Brazil. The next one is coming from Egypt, Professor George Nashed, who is a professor of general and bariatric surgery, Qasr Al Aini, Cairo University in Egypt, and is chairperson upper GI surgery unit at Cairo University, Egypt. And the last one, but not least, is coming from Spain. It's Professor Ramon Vilallonga, who is a head of the endocrine, metabolic, and bariatric surgery unit, Vall d'Hebron, Barcelona, in Spain. And a professor of surgery at the Autonomous University of Barcelona, Spain. And I would like to ask now the Dr. Nogueira to introduce our first speaker, Dr. Colleen Kennedy from US, who is going to give us a lecture. Is Dr. Nogueira with us?
Sorry. Thank you, Professor Karin. It's my pleasure to introduce Dr. Colleen Kennedy from the United States. Dr. Kennedy is the medical director of bariatrics at both Baylor Scott and White in Plano, Texas, and Texas Health Presbyterian Hospital of Rockwall. She serves on the executive committee of the Texas Association of Bariatric Surgery and on the board of directors of the ASMBS. Dr. Kennedy, welcome.
Thank you, and good morning. I appreciate being asked to give a talk here. I am looking for, there we go, my slides, and we're going to share my screen. I have been asked, and I appreciate being asked to talk about innovations in enhanced recovery strategies, both ERAS and BSTOP. I am in solo private practice in Texas, and so this is a very great opportunity for me. I'm going to be talking about the introduction to ERAS protocols in bariatrics, the BSTOP protocols for enhanced pain management and recovery, integrating the two protocols and practical considerations, and the impact this is seen to have on patient outcomes and future directions. ERAS protocols have been around for a while. They started outside of our field and moved into bariatric surgery, but the principles are using multinodal analgesia, using different pain management techniques to reduce opioid use and enhance comfort and decrease complications of opiates, early mobilizations to get patients up and moving quickly after surgery to reduce complications such as blood clots and pneumonia and speed recovery along. Optimize fluid management. Previously, we might not have been so careful in balancing fluid intake, which would cause problems with fluid overload or pre-renal state, and minimizing fasting state to promote faster healing and preserve energy. The ERAS evaluation of bariatric surgery, the large trial that was done actually in the United States as part of our MBSA QIP, which is our quality protocol in the United States, was called Energy, which was employing enhanced recovery goals in bariatric surgery. And this was a nationwide project looking at the use of ERAS protocols in bariatrics. And this covered about 14,000 different centers. And the outcomes show that ERAS protocols could be implemented in bariatric surgery without any complications. The key components looked at include preoperative counseling, educating the patients up front about expectations and recovery, and improving their engagement and having them buy into their surgical recovery is important. Carb loading in ERAS in other fields has been shown to reduce insulin resistance and enhance postoperative recovery. What I have found, that breaking their ketosis decreases nausea. Opiate-sparing analgesia. If we minimize opioid use, we will have less problems with constipation and respiratory issues, and also less issues with complications of sleep apnea. They reported 40% reduction in opiate use, just implementing ERAS protocols. Giving prophylaxis for nausea and vomiting will decrease postoperative nausea and vomiting by 20 to 50%. Early feeding, which will promote gut function and speed recovery, and protection for DVT prophylaxis. So safe early mobilization, early discharge, preventing blood clots. The evaluation was looked at a few years later in 22. This was actually in the worldwide evaluation from the World Journal of Surgery in 22. And this was looking at what has changed. The recommendation in here looked at level of evidence and recommendation for the strength of it. Some of this will be covered by other speakers, so I will skim over those sections. The preoperative care includes, once again, the education. While the level of evidence is low, the recommendation is strong for preoperative education and information. This is a low-risk implementation that has good results, hence the strong recommendation. Indications should be reviewed, and standard protocols and guidelines should be used. There is good evidence to follow guidelines. There is good evidence that stopping smoking before surgery improves postoperative recovery. They should be stopped at least 1 month before surgery. For people with abuse issues, recommendation should be abstinence for 1 to 2 years preoperatively. But we must recognize that there's a risk of relapse postoperatively. The level of evidence for the alcohol abstinence for a year is low, but it is recommended strongly to have patients who have an alcohol abuse issue stop drinking. Preoperative weight loss to improve postoperative complication has good evidence that if they are adhering to the diet preoperatively, they have lower postoperative complications. My personal bias is if they manage to do a preoperative liquid diet and preoperative weight loss, they are more likely to be comfortable with the liquid diet postoperatively and not have the early switch to foods that they should not be eating, which has more complications. And then prehabilitation is getting them stronger before surgery. The level of evidence is low, so the recommendation is weak. Postoperative care, they have a wide variety of meds. There is low evidence for giving steroids to improve postoperative recovery. There is very low evidence for statin use. The use of beta blockers newly is not recommended, but use of beta blockers in individuals who've already been on it is strong, so it's recommended to continue. The fasting, patients should have solids or calories up to 6 hours before induction and clear liquids to 2 hours before induction. Diabetes would follow, but they must watch more closely to make sure that their sugars do not drop or if they have issues with gastroparesis. Carb loading, once again, is considered to be weak. I personally am a strong believer in a carbohydrate drink preoperatively to break the ketosis. And postoperative nausea vomiting should be given up front. Intraoperatively, this will be talked about a lot in our anesthesia, so I'm going to skim over it, but there is recommendations for anesthesia protocols and ventilation strategies to have a more successful postoperative course. Once again, post-occupative oxygenation, discussion of people with sleep apnea should be wearing their CPAPs. Individuals with their home CPAP should bring it with them. This will prevent respiratory issues post-operatively. Thromboprophylaxis should be implemented as soon after surgery as possible. Doses and duration of treatment should be individualized based on their risk of DVT. Individuals should be placed back on liquids within several hours after surgery. That has good evidence that it improves post-op care and tolerance of POs. And vitamin supplementation should be given intraoperatively, postoperatively, and continuously. PPIs should be continued postoperatively for at least 30 days. There's not enough evidence in the gastric bypass, but there's not enough evidence for the sleeves. However, since individuals with the sleeve have a higher incidence of reflux, there is weak support for continuing PPIs. In 2024, this was looked at again, and the bariatric surgery outcomes for individuals who had embraced and followed ERAS protocols for bariatrics. Three reviews were looked at. All studies following the ERAS protocols demonstrated that less opiate use, less postoperative nausea, less vomiting, less ER visits, less decreased length of stay, and no increase 90-day readmission or rates of adverse effects. So they show that the patients do better and they're not having higher complication rates. The next that came along was, well, we've got this, well, let's go one step better. And then it was B-stop protocols, which was enhanced pain management and recovery. The theory behind this was to use a multimodal opiate-sparing analgesia, non-opioids, and regional techniques to control pain while minimizing opioids. The rationale was that evidence showed minimizing opioids improves recovery quality by improving mobilization and respiratory status, and it shortens hospital stays. The original B-stop protocol was once again an MBSA QIP protocol that was implemented. It was reported in 2025 after review. And this was looking at reducing opioid use after bariatric surgery. The purpose was to give Tylenol and anti-inflammatories before surgery to minimize pain onset and opioid use. A review of patients' perception of pain relief, IV Tylenol was actually considered to be better pain relief than narcotics. And so giving IV Tylenol up front definitely was helping with preoperative analgesia. Local anesthetic with a nerve block, which could be used via tap block by your anesthesia colleagues, or by a on-cue pain ball, which gives a localized and continuous treatment with bupivacaine for 72 hours, or from direct block with a 72-hour Exparel dose during surgery for targeted pain relief, so they wake up without pain. Ketamine infusions can be used intraoperatively to enhance analgesia and reduce opioid requirements. That is not, I personally am not a standard user of ketamine infusions by my anesthesia colleagues, but we have found this to be useful in individuals who have chronic pain. Carefully reduce opioids postoperatively to prevent dependence and side effects. And then get patients up, moving, walking earlier, improving recovery and reducing complications. If you combine these interventions with the ERAS pathways, you'll have benefits in pain control and recovery. And this is what I have implemented in my practice, as well as most people I know. Comparative outcomes, if you use the B-Stop protocols, there was up to a 50% reduction in opioid consumption in the hospital. And there's a shorter length of stay, up to 24 hours shorter, between a half and a whole day shorter, an average of those using standard care. There is a decrease in opioid-related adverse events, including the nausea and respiratory depression that we have all struggled with. And the patient reports similar pain control. There is less money spent and lower dependency on narcotics seen in follow-ups. So when you're integrating the two protocols, what do you have to do? Well, first you'll look at the impact of ERAS plus B-Stop on patient outcomes, length of stay, and opiate scripts after bariatric surgery. What they've seen in retrospective review in obesity surgery was that in population of sleeves and gastric bypass, the most common comorbidities were sleep apnea and reflux. The outcome was a decreased length of stay, decreased opiate use, same amount of complications, and same amount of readmissions. So it did not worsen the outcomes, but it did improve opioid use and length of stay. It is a safe and effective combination to take care of our patients. So this will lead to a faster recovery, accelerate return of function, and shorten length of stay. There's fewer complications, reduce postoperative risk and variability in care without increasing readmissions. Good pain control, multinodal opioid-sparing strategies, improve comfort and mobilization. And then for this to work, it has to be the whole team. This starts on the first visit with the patient with good expectations of what they will be seeing, and continuous reinforcement of the protocols with our patient. Where does this lead? Well, we've seen this. There's decreased post-op narcotics on discharge. The next step in these studies is the B-Stop/D, which is the discharge evaluation, where the amount of narcotics prescribed on discharge is looked at based on the amount of narcotics used on the last day in the hospital. If the patients do not use narcotics, they go home without narcotics. The most that patients are getting is up to 10 tablets of typically either oxycodone 5 milligrams or tramadol. And in my own practice, there is about 60% of my postoperative patients go home without narcotics at all. If you limit it to have patients who do not have any history of chronic pain, overall, it appears, but the final data is in review, but there's at least 50% of patients across the entire study went home without narcotics. What does this mean? It's easier to have outpatient surgeries. In 2026, there is more and more push to have bariatric surgery be an outpatient procedure, similar to hip replacements and some spine surgeries. It has been pushed by the insurance companies and hospitals. So more surgeries are performed in the ACC with good outcomes and excellent pain control, and more outpatient surgeries. There is less post-op dependence on narcotics. When you have them, we're getting less pain meds intraoperatively, less pain meds postoperatively, and good pain control with other agents such as Tylenol, gabapentin, muscle relaxers, and the sort. And there is a faster return to work and a quicker return to quote-unquote normal life. I thank you for letting me speak on this. When I use this protocol, my patients actually get Tylenol, Robaxin, and gabapentin pre-op, as well as their antibiotics, and Emen for extended release nausea. Post-operatively, they have scheduled Reglan for nausea, as well as scheduled gabapentin and Robaxin and Tylenol. And then we supplement it with pain meds with dilaudid or oral pain meds post-op day 1. And it has led to a much lower need for narcotics and narcotic scripts. I rarely have to give extra narcotics. Thank you.
Thank you very much for a nice presentation. I would like to say that we used to use some of the steps you mentioned in my previous hospital, and we were very satisfied. But it was hard work with anesthesiologists firstly to start with this type of anesthesia. Was it hard for you to start it in your hospital?
So I like to say I'm very spoiled in my hospitals. I've been in both my hospitals for over 15 years, and I've worked with the anesthesiologists in the groups, and they have seen how we have evolved over time, and they have embraced wholeheartedly the changes. When I started doing on-cue pumps in all of my post-op patients, all the nurses on the floor came in and asked, what are you doing differently? Your patients don't have pain. And so as more and more of the reports came back, they embraced it fully. And so now they just ask me when there's changes, and we discuss it at one of our multidisciplinary conferences, and it quickly goes across.
Yeah. Now working with the, sorry, someone else. Sorry.
It's okay. Dr. Colleen, with B stop achieving 50% of opioid reduction, what is the remaining 50%? Do you think is it visceral pain that these protocols still don't address?
I personally think some of it, there is some visceral pain. Some of it may be anxiety-associated pain. I am looking at in my own group on whether or not in individuals we should give low-dose anxiolytics, because we all know that anxiety increases muscle pain and visceral pain. Often where the pain that I see is nerve pain where the gabapentin is not touching it, and I will have them use a topical lidocaine patch, and that helps a lot. Sometimes people just have a lot of these things. It's hard to pin it down to one.
Thank you.
Great
presentation.
Yeah. Dr. Colleen, I have a comment and a question for you regarding this integrated multimodal enhanced recovery strategy in bariatric surgery. Sometimes you have patients with reflux esophagitis, and I think those patients, we cannot allow them to drink fluids until 2 hours prior to surgery. I think this is risky for aspiration in some patients. Second point is regarding the post-operative pain. I think just local infiltration of the port sites before you start, preemptive local infiltration, and subphrenic local anesthetic drip infiltration at the end of the procedure might help in decreasing narcotic use in those patients, in those bariatric surgeries.
I agree with you. We need to definitely individualize our patients. My anesthesia group is not really excited about my diabetics having clear liquids till 2 hours beforehand. So often on the diabetics, we have to back that out to 4 hours beforehand. The individuals with severe reflux, we have had conversations, and some of them will do 4 hours beforehand. So nothing is one size fits all, unfortunately. But that's how the art of medicine gets to play in instead of just following a cookbook. I agree with you that I like to infiltrate we will place, if they request a tap block because the patients are unnerved by the idea of an uncued pain ball post-operatively, we place the tap block up front before you make incision. It often helps with the post-op pain control, similar to your local infiltrating. I have never done the subphrenic lidocaine post-operatively, but my uncued pain ball hits under both, goes straight under both rib cages and hits the nerves coming out from under the diaphragm on both sides, so it probably has the same effect.
Yeah, thank you.
I agree with Dr. Nashed about giving liquids shortly before surgery in other group of patients, and those are those patients who are having GLP-1 analogs, because on those patients, aspiration can be also a risk.
Yeah, I actually stopped the GLP-1 so that it's about 2 weeks before surgery when they stop it. It's to help to decrease the reflux and aspiration risk. But I agree with everyone on a GLP-1 these days, we have to be careful.
And regarding a multimodal approach, I'll be discussing the visual blockade in a while. It helps a lot.
So I think now we are going to move to the next speaker. I will introduce Dr. Laura Campiglia from Italy. Dr. Campiglia is a consultant anesthetist and intensive care in Italy. She will speak about novel anesthetic strategies to facilitate enhanced recovery after bariatric surgery.
Hi, Marco. Non le diapositive?
Condividi sotto.
Hi, thank you very much for inviting me. I am very honored to be here with you today. I'm going to talk to you about novel anesthetic strategy to facilitate enhanced recovery in bariatric surgery. And enhanced recovery after surgery is a modern approach to reduce postoperative stress, and it helps patients to recover more quickly following surgery, leading to improved outcomes in postoperative morbidity and the length of hospital stay. And ERAS, implemented initially for elective colorectal surgery, has been extending over time to many other surgeries, including bariatric surgery. And so in 2021, with an update in 2022, ERAS guidelines for bariatric surgery were published by the ERAS Society. And the key component followed by mass institution comprehensive preoperative counseling, standardized anesthesia protocol, and the management for postoperative nausea and vomiting, the prevention of insulin resistance and catabolism. And ERAS bariatric surgery pathway comprises 3 phases. We have the first one with pre-admission care with physical, respiratory, and psychological rehabilitation, glycemic and metabolic stabilization, and perioperative risk evaluation. And for the intraoperative period of time, the attention is on hemodynamic monitoring and oxygen delivery optimization, but also on depth of anesthesia and also on post-operative delirium prevention, on nociception and multimodal analgesia, low pneumoperitoneal pressure, protective ventilation, and courierization. And after that, we have to consider the first phase with the post-operative period of time and the criteria for ICU admission. And so preoperative information and counseling are key items for managing the expectation of the patient. And the smoking cessation for at least 4 weeks reduces postoperative surgical and pulmonary complication by 41%. And we have also to optimize the fasting blood glucose level through diet, through physical activity, and also with pharmacotherapy. And the concept of prehabilitation 4 weeks before surgery includes interventions aiming at increasing physical functioning before surgery, which in turn may improve recovery and reduce postoperative morbidity. And specific inspiratory muscular training preoperative improved postoperative oxygenation. And so we have to use physiotherapy in both preoperative, in the preoperative period of time, but also in the postoperative period of time. We have to consider pre-oxygenation before anesthesia induction. We have to use protective ventilation with low tidal volume, with PEEP, with low level of driving pressure under 14 centimeters of water. And we have to consider also positive airway pressure after surgery to prevent deoxygenation after extubation. And so we have to consider in a preventive way. And we have also to consider that metabolic syndrome, low level of HDL, age, and BMI are all factors for cognitive impairment. And so prehabilitation has to look also to prevent postoperative neurocognitive disorders. We have to look also to preoperative assessment. We have a lot of ways to look at preoperative assessment. One of these is obesity surgery mortality risk score, which considers BMI greater than 50, the gender like male, hypertension, pulmonary embolism, and age over 45. And a score more than 4.5 indicates a high risk of postoperative complication, and so maybe the patient would need of being monitored a lot of hours in intensive care or in subintensive care unit. And ERAS guideline focus on monitoring, especially on fluids monitoring, on depth of anesthesia, and on neuromuscular blockade. But if we want to reduce opioid consumption and if we want to gain more hemodynamic stability, more respiratory stability, and to control more nociception, we should use a precision anesthesia which focuses on individual needs and characteristics rather than using an outfit-all approach. And so we need monitoring. Inadequate monitoring during bariatric surgery, because bariatric patients are high-risk patients, needs hemodynamic monitoring, pain monitoring, processed electroencephalography, temperature, and also neuromuscular blockade with a train or for stimulation. And let's start with hemodynamic monitoring. We have different ways to look to hemodynamic monitoring, like non-invasive at time, non-invasive continuously, like clear sight system, minimally invasive monitoring with uncalibrated system like pulse contour, spectral analysis, and calibrated system for high-risk patient and high-risk surgery. And we have also the gold standard for hemodynamic monitor, which is echocardiography, both transthoracic, but especially transesophageal. And with this kind of monitor, we can look to many parameters like stroke volume variation, pulse pressure variation, cardiac output, mean arterial pressure, oxygen delivery, index of force contractility, and systemic vascular resistance index. And we have to consider the gray zone for stroke volume variation and pulse pressure variation from 9 to 13%. And we have also to look at the arterial line, arterial curve, and for its accuracy. And so we have to avoid overdamping and underdamping. In this study, they want to look to the value of mean arterial pressure, and it means hemodynamic instability. And if the patient has value of pressure below than 60 millimeters of mercury, we will have an increase of postoperative complication like acute renal injury, myocardial injury, and also an increase in mortality. And how longer is the period of time below 60, we will have more complication in the postoperative period of time. And so we have to consider mean arterial pressure for hemodynamic stability, but also cardiac output and stroke volume to avoid tissues hypoperfusion. We have to look to stroke volume variation and pulse pressure variation to optimize intraoperative fluid administration. And we have also to monitor depth of anesthesia and nociception to avoid hemodynamic instability. And for patients of high risks of cerebral hypoperfusion, we have also to consider to look to NIRS and so to cerebral oxygenation to avoid cerebral hypoperfusion during surgery. Also considering the patient positioning and also the intraoperative abdominal pressure. And when we talk about fluid management, we have to avoid hypovolemia because it altered tissue perfusion, it increased renal failure and also splanchnic ischemia. But on the other side, we have to avoid hypervolemia because it decreases oxygen to tissues and it worsens further when associated to anemia and hypoxia. And so the aim of the hemodynamic monitoring is to optimize perfusion pressure and oxygen delivery to maintain an adequate cellular metabolism. And let's talk about processed electroencephalography. And this kind of monitor will reduce adverse effects like hypotension with the cerebral hypoperfusion, acute kidney injury and myocardial injury, delirium and postoperative cognitive dysfunction, awareness, and we can see also asymmetries during surgery when we use a bilateral sensor. And so if we look to a G-guided anesthesia, we have to go beyond the index. We have to look to the raw trace, density spectral array, and not only the number, no histology. And so if we look to density spectral array, we can see the correct depth of anesthesia, the pattern of nociception with delta arousal, with alpha dropout, and with beta arousal. We can see also hypoperfusion and frail patient. We can see asymmetry, but the most important is a good emergency from anesthesia because it's the most important thing for high-risk patient like bariatric patient, because a late awakening from anesthesia will increase postoperative complication, especially on the respiratory side. And so if we see a decrease in amplitude and in voltage of raw trace, we have to ask to ourselves if we have a problem with the depth of anesthesia or with nociception. And after that, we have to look to other causes like hypoperfusion, hypoglycemia, and so we have hypotension, and so we have to correct them. And so from density spectral array and the raw trace, we can see the balance of oxygen delivery on one side and oxygen consumption to the other side. Let's talk about pain. We can monitor pain with the system based on central nervous system like Kunox entropy and DSA variation in processed electroencephalography. We can see nociception also by autonomic nervous system, but in this kind of patient, they use drugs, and so it's not so correct during surgery, and also with the spinal cord reflex responses. And opioid-free anesthesia is maybe the safest anesthesia method for bariatric patients. And opioids are replaced by other adjuncts like ketamine, lidocaine, dexmedetomidine, and magnesium. And with this kind of anesthesia, we will have less postoperative vomiting and nausea and less postoperative pain. And also it improves postoperative recovery. And so this kind of drugs will decrease the duration of post-anesthesia care unit length of stay, and also paracetamol and lidocaine will reduce the overall hospital length of stay. And let's talk about neural blockade. And it was found that the rector spine block increased the quality of recovery in bariatric surgery and decreased postoperative pain and opioid consumption. On the other side, transversus abdominal plane block had no additive benefit to multimodal analgesia regimen in reducing postoperative pain and opioid usage. And parogastric neural blockade is the most effective in control postoperative pain, postoperative nausea and vomiting, and in the recovery after surgery. And when we talk about TOF, we know that muscle relaxation is crucial for laparoscopic and robotic surgery because it helps us to use a protective ventilation, but also we can reduce pneumoperative intra-abdominal pressure. And this is also possible thanks to systems such as AirSeal, which maintain constant intra-abdominal pressure and provide the surgeon with excellent visibility of the surgical fields, allowing them to work at low pressure with low postoperative complication at 8 and 10 millimeters of mercuries. And so this avoids the consequences of high insufflation pressures such as hemodynamic and respiratory instability, splanchnic and renal hypoperfusion, and increased postoperative pain. And let's conclude with take-home messages. And so multidisciplinary team for rehabilitation with the pre-counseling, with the respiratory exercise, psychological counseling, and also with improved metabolical balance. We have the need for an adequate intraoperative monitoring to optimize all parameters and especially oxygen delivery, which is our goal. And not protocol-driven anesthesia, but rather personalized that follows and adapts to pathological values for each individual patient, and so the patient at the center of this pathway. And the use of multimodal analgesia with neural blockade to reduce opioid consumption, postoperative pain, and postoperative also length of stay in hospital. Postoperative optimization with the resumption of physical activity reduce the risk of postoperative complication and shorten hospital stay. Thank you.
Thank you very much, Dr. Laura. Interesting. You know that surgeons lack some of the info you already gave in your talk. I just have a question about the total intravenous anesthesia. Does it make a difference in recovery rather than using combination of intravenous and inhalational ones?
Yes, we have an improved recovery after surgery with intravenous anesthesia, but it needs monitoring. We have to monitor all time of anesthesia, and we have also to change drugs, also because bariatric patient have a different pharmacokinetic for drugs, and so we have also to consider the unpreventable answer to this kind of drugs. And so we have to monitor depth of anesthesia with the processed electroencephalography, also to optimize analgesia and avoid nociception during surgery. And after that, we will gain an enhanced recovery.
Thank you. Thank you very much for
You're
this
welcome.
kind presentation. I would like also to congratulate Dr. Kennedy for her approach and vision on the multidisciplinary integrated team. It was very clear to me and very appropriate the way that was explained. However, I would like to go on this last presentation, Dr. Campiglia. So at the end, I believe you do a preoperative visit in the outpatient clinic. Here's where you can check either with some scores you have mentioned or your approach, experience, and anesthetic evaluation, which patients have to go to specific pathways. This is what you mentioned specifically
Yes.
in your take-home messages. Which would be the patient that would maybe require the less anesthetic preoperative preoperative interventions, and which would be the one you fear that you can see sometimes? I mean,
Yes.
not the one you did once a life. Everybody has once a life, but let's say, for example, BMI is 45, maybe males you mentioned, no, with
Yes.
metabolic syndrome. What is your point of view from the GLP-1s suppression before surgery? Do you recommend 1 week, 2 weeks? I don't know if you can give some maybe very specific details to the audience to say, I would take care specifically on these topics from my experience.
Yes. We have to consider a lot of topics on this kind of patient. And first of all, we have to consider what the surgeon is going to do and how long will be surgeries. And it's very important for this kind of patient. Also, the positioning during surgery, anti-Trendelenburg positioning with the high risk of hypoperfusion, hypotension during surgery. And so before surgery, we have to look with care to respiratory pattern, maybe the risk of apnea, and so stop-bang index. But also on the other side, we have to look to cardiac parameter, hemodynamic parameter before surgery, like atrial dilatation, ventricular dilatation, but also septal hypertrophy with echocardiography, because there is also an increased risk of hypotension in this kind of patient. Also, the great risk for us is the risk of SAM, systolic anterior motion of the mitral valve. And so we have to consider this parameter, and also metabolic balance. And after we can have a score, but I think that we have to consider how the patient was stable during surgery. And after that, we have to put this data all together: stability, intraoperative stability, and the preoperative evaluation put together. And after that, we will decide for the safety of the patient where the patient will be recovered after surgery. If we need monitoring, more monitoring, or also non-invasive ventilation, we have to monitor patient after surgery in intensive care unit or subintensive care. If patient were stable during surgery, we can look to his values maybe for 8 hours, 6 hours after surgery. And so in a post-operative care unit. And so I think this is another important aspect to monitor the patient, because in this way we have a full picture, a full photography of both the preoperative condition of the patient and intraoperative condition of the patient.
I agree a lot. Thank you.
You're welcome.
Dr. Campiglia, very interesting presentation. The recent Prospect 2025 update now recommends step block as a standard for the sleeve.
Yes.
Given your experience, what is your opinion on that recommendation?
I work in robotic surgery with a lot of surgical specialties. And I don't like transversus abdominal plane, because it can succeed in hernial repair, but not for visceral pain. With transversus abdominal block, visceral pain is not covered, and the patient will have pain after surgery. We have to cover visceral pain, and we have tried last week also paraganglial block, and it's very useful. And the patient without any opioids during surgery and after surgery, he felt so good, so good. And after 6 hours after surgery, he was able to sit on the bed, and it was a lot of satisfaction for us, because to see patient without pain, I think is the goal of anesthetist and of my work.
Thank you.
You're welcome.
Hi. Can anyone hear anything?
I can hear you.
Yeah, I
Yeah.
can hear you, but
Yeah, we can hear you.
Yeah, me too. Because
okay.
We're supposed to move to the next talk.
Okay.
yes,
Shall I introduce then the next talk? If you want.
Yeah,
So
please go ahead.
it's our pleasure also to introduce Professor Andres Hassen from Colombia. Professor Hassen will talk to us about intraoperative autonomic blockade, enhancing anesthesia and ERAS protocols in laparoscopic sleeve gastrectomy. So thank you very much for being in this webinar, Professor Andres Hansen, and you are more than welcome to start your presentation. Thank you.
Can you see my screen? Is the
yes,
presentation on screen? Okay. Well, I want to thank for the kind invitation. I'm addressing kind of a new topic because since the development of minimal invasive surgery, of laparoscopic surgery, somatic pain importance in the postoperative period has decreased a little, but visceral pain is still an issue. So as you are aware, pain is not just a symptom, it's a whole syndrome because it's frequently associated to other symptoms as nausea and vomiting. Visceral pain is the predominant form of pain and after most of the laparoscopic procedures today, and in many surgical procedures, nausea and vomiting remains a huge problem. And it is especially important after sleeve gastrectomies. And many groups describe a high prevalence over 65% of patients having nausea and vomiting. Also, there is a tendency towards ambulatory or outpatient sleeve gastrectomies, and this policy is gaining popularity, but it is still extraordinarily low, the adoption of outpatient sleeve gastrectomies, under 30.1%. And there is still a problem with the readmission rates that range from 3 to 6.5%. Being dehydration, nausea, vomiting, and pain, the most common factors that cause readmissions. So several years ago, we developed what we initially called paragastric neural block. We don't call that paragastric anymore because the wider concept of autonomic blockade probably englobes more efficiently what we do today. This is our first randomized clinical trial. We randomized 150 patients in two different groups, one with what we in those days called paragastric block, and a control group. And this is the way we used to perform the blockade. We use 0.5 bupivacaine with 8 milligrams of dexamethasone to block along the vagus nerve in the lesser curvature. And also we injected the same preparation around the celiac axis. Initially, we started in this randomized control trial, we performed the blockade at the end of the procedure. And for performing the blockade around the celiac axis, we rotated this. We used to rotate the sleeve to the right to expose the celiac axis, and we injected there the bupivacaine plus dexamethasone. This was more or less the procedure we do. You can see the hepatic artery, the left gastric artery, and we use an insulin needle to inject the preparation around along the vagus nerve, as you can see in the image. And after that, we will do the same around the celiac axis. We always aspirate to get sure that we are not in a vessel. If we obtain blood, we stop injecting in that spot, and we move to another spot. You can see clearly the vagus nerve along the lesser curvature of the sleeve, and the goal is to elevate the nerve. As you can see, the whole path of the vagus nerve can be seen along the lesser curvature, and we are injecting the preparation there. After that, we will inject also along a side of the celiac axis, as you will see in a minute. Initially, we didn't dissect for performing this blockade around the celiac axis. But as you will see in a minute, we today perform the blockade in a different way. So how were the results? These are the patient-reported visual analog pain scores at the first hour, at 8 hours, and at in the first day, the 24 hours after the laparoscopic sleeve gastrectomy. And you can see that the pain scores were significantly lower in the blockade group compared to the control group. At 8 hours, there was a still significance, but the results show no statistical significance 24 hours after the operation. So the lasting of the effect is about 18 to 20 hours, and we found no difference after that period. Regarding the number of analgesic doses administered, we also found that initially there was a difference at 8 hours mainly, and the difference was statistically significant. So how many doses the patient required? There was a significant statistical significance at 8 hours mainly, with most of the patient needing no analgesics or just a single dose. So you can see here a comparison of the opioid doses between the blood group and the control group, and it's evident that we found a difference. So after achieving this, we started studying how this blockade should impact the anesthetic agent consumption during the laparoscopic sleeve gastrectomy. And we started applying the blockade at the beginning of the procedure in one group and at the end in the other group. And also in this study, we started doing it a little differently. We created a window in both sides of the left gastric vessels to expose the base of the left gastric vessels to inject the bupivacaine and the dexamethasone around the base of the left gastric vessels and at the rise of the celiac trunk, as you can see in the image. We also performed the blockade along the vagus nerve, the vagus nerve path, because we hypothesized that this reduces the tone of the muscular fibers of the gastric tube, decreasing the intraluminal pressure of the sleeve, contributing to decrease pain, the oppressive pain that patients report in the epigastrium, and also the nausea and the vomiting. This is a short video on how do we perform this today. This is actually a gastric bypass, a robotic gastric bypass, and as you can see, we created a window in the lesser omentum, in the hepatogastric omentum, and we injected at the base of the left gastric vessels. We are injecting the preparation along the vagus nerve path, along the lesser curvature, as you can see here. and it takes under 4 minutes to perform the whole blockade. So what we found in this study, when we adjusted the consumption of remifentanil and halogenated agents, remifentanil consumption adjusted for in micrograms per kilogram per minute were significantly lower in the blockade group when we performed the blockade at the beginning of the procedure, and we resume all the methods and all the actual procedure we do in this chapter in the book, The Perfect Sleep Gastrectomy, which second edition was released in April 2025. So intraoperative autonomic blockade, when it's performed at the onset of the laparoscopic sleep gastrectomy, has demonstrated to be safe and effective in our today 4 randomized controlled trials. When it's performed at the onset of the laparoscopic sleep gastrectomy, it resulted in a significant reduction of opioid consumption. Today, all of our patients are discharged with no opioids, just paracetamol by mouth, and that's it. Our readmission rate is under 4%, and this procedure seems to promote hemodynamic stability during the critical phases of the procedure. It was reported by our anesthesiologist that when we apply the stapler, the heart rate uses to rise. But when we do the blockade, first of all, you will find out that the blockade was successful because the patient will experience a drop of the heart rate at 10 beats per minute in average, and the mean blood pressure will drop by 10 millimeters of mercury in average after 10 minutes of the blockade. And the patient remains stable. Actually, as we demonstrated earlier, the anesthesiologist is able to reduce the doses of opioids and halogenated agents during the surgery. So our previous reports also shown the potential of the blockade to decrease nausea and vomiting and the need of analgesics. So we are very, very encouraged to increase our series, which is over 2,000 patients today, and to extend these applications to other procedures. We're just published and preparing surgical endoscopy using the autonomic blockade during laparoscopic cholecystectomies, and it's very interesting. And it has been done for colectomies using the block around the inferior mesenteric plexus for left colectomies and around superior mesenteric artery in right colectomies. So as I said, it has resulted in a significant reduction in opioid consumption. It has shown an important potential to decrease postoperative pain and associated symptoms as nausea and vomiting and the need for the analgesics. So our results suggest that this autonomic blockade is safe and is very effective addressing visceral pain, analgesic requirements, especially opioids, and the associated autonomic changes that usually occur during early postoperative course of patient after sleeve gastrectomies. Adequate causes, as I said before, adequate blocking causes a decrease in heart rate and a decrease in mean arterial pressure, and that could be indicators that the blockade has been carried properly. The use of anesthetics with a longer duration in effect as lysosomal bupivacaine may prolong the period of the blockade. But we did a small study and we couldn't find a longer period of action using Exparel and comparing it to our usual mixture of bupivacaine plus dexamethasone. So the proposed mechanism of action of the blockade is a reduction of the sympathetic and the parasympathetic influence on the stomach and the surrounding structures. When you blockade the parasympathetic influence, there will be a decrease in the muscular tone of the stomach, decrease in the intraluminal pressure, and probably that's the mechanism for decreasing the pressure sensation that patients report in the epigastrium, and probably decreasing also nausea. And when we block the sympathetic fibers or ganglia around the celiac axis, we block the transmission of the visceral pain to the spinal cord. And that's the proposed mechanism of action of this blockade. So thank you very much.
Thank you very much. If any of the moderators wants to add or
Doctor.
a specific question.
Yes, of course. Dr. Andres, this is a brilliant and very elegant technique. Congratulations. With over 2,000 patients in your series, how reproducible is it? Have other groups adopted, and do they achieve similar results?
Yeah, it has been adopted widely. Actually, we're working together with several groups worldwide. And the initial concern is, the potential complications of making punctures in the tissue around the big vessels or the celiac, but it's very reproducible. We haven't had major complications performing the technique, just small bleeders or hematomas around the stomach, and they resolve spontaneously. We haven't had any major complication. The other thing is it's not long time consuming. Okay, it takes just 4 minutes to perform the complete blockade. We add some blockade on the diaphragm nerves when we are doing hiatal hernia repairs, because one of the limitations in our initial series was that those patients that required hiatal hernia repairs have pain. Okay, the pain scores increase a little, and since we are also blocking around the inferior diaphragmatic vessels, those pain scores have dropped dramatically. So we strongly feel that it is easy to perform, that the learning curve is pretty short, that it's not time consuming, and once you feel comfortable with this, every surgeon say that my patients don't have that pain, and all of them are released, are discharged on the 3rd day. But you can actually predict in the recovery room which patient got the blockade and which patient didn't. Okay, the nurses learn how to predict that, because it is so geometric. It's so evident that the pain scores and the associated symptoms are really a difference. In those patients without the blockade, you always see them with a device for recollecting their vomit, or they're having important pressure sensation in the epigastrium, and the nurses today can predict which patient got the blockade and which patient didn't.
Very interesting. Thank you.
Thank you, Dr. Andres, for this interesting presentation. I just have a question about, most of pain in the early postoperative period is epigastric, lower chest or chest tightness, and refer to the shoulder. So, does this autonomic block affect these types of pain, the chest pain and the referred shoulder pain? This is
Yeah, the
number one.
referred pain to the shoulder has been attributed to the irritation of the diaphragm with the CO2. We add some, in every patient, we perform tap blocks, and we aspirate very carefully the pneumo after the procedure, mainly in the right upper quadrant with the suction cannula. But yes, the only discomfort some of these patients have is a very slight pain in the left shoulder, and it's probably due to the pneumo. The other thing we have been experiencing is in lowering the pressure. One of our associates have noticed that when we complete the blockade, the visceral blockade, the abdominal wall relaxes. We have no explanation, physiologic explanation for that, but she actually can feel a difference. She's handling the camera, and she can actually feel that the abdominal wall feels different after the blockade. We don't have a neuropath for explaining that phenomenon, but has been noted, and we are trying to find out how to explain that. But lowering the pressure of the insufflator, we work with just 12 millimeters of mercury, using routinely infiltrate the port sites at the beginning. We perform a tap block at the ending, and doing the autonomic blockade at the beginning of the case, we actually have achieved a very, very comfortable postoperative course. We are using no opioids in the postoperative in postoperative period, and our patients are going home just with paracetamol.
So thank you. This was my second question. So did you have a control group regarding those you used to infiltrate the port site before you start the surgery, and then you do at the beginning autonomic blockade versus those with autonomic blockade alone?
The only difference was the autonomic blockade. We performed initial infiltration of the port sites. We perform tap blocks in both groups, and the only difference between groups was the autonomic blockade.
Okay, thank you.
Thank you very much. I would like just to ask a very quick question. Do you see any difference between patients with small complications like bleeding after? Do they experience more pain, more nausea, or it's still the same?
No, the bleeding has been minimal. Actually, you can see a small hematoma at the injection point, but we haven't had any reoperation, any difference in pain scores in those patients in which we noticed a small hematoma at the injection site.
Okay, thank you. So if no questions, we can move on the last presenter, and that's Dr. Elmevi Mohammed from Egypt, who is a lecturer and consultant in bariatric and laparoscopic surgery, Kafr Sheikh University Hospital in Egypt, and he's going to tell us something about deep vein thrombosis prophylaxis.
Thank you, Dr. Karin. Is my voice clear?
Yes.
Okay, my screen is up. Okay. So we are going to talk about the current evidence about direct oral anticoagulant. Okay. Because, of course, obesity is a major risk factor for DVT and other VTE incident. Bariatric surgery patients face a high risk of post-operative VTE, different VTE incident like pulmonary embolism, portal vein thrombosis, or DVT. The ACCB recommends antithrombotic prophylaxis for all patients. The incidence of VTE post-bariatric surgery actually varies from 0% to 3.5%, portal vein thrombosis 0.5%, and interestingly, that the leading cause of post-bariatric mortality is pulmonary embolism, that 30% in autopsy studies find the main cause of morbidity and of mortality in bariatric patient is pulmonary embolism. The risk factors for the patient, according to the Caprini score, all our patient is either that a medium or a high risk patient. So according to Caprini score, all our bariatric patient need some VTE prophylaxis, post-operative and even pre-operative. We, as a bariatric surgeons, we don't have a standardized risk assessment tool for our patient that we consider all our patient is at high risk for VTE, but the other factors like patient-related factors like the prior VTE, the patient BMI, age, gender, immobility, hormone therapy, OHS, hypertension, venous stasis, patient-related that may increase the risk for VTE. And of course, there is some surgery-related issues like operative time, procedure type, and surgical approach, either open, laparoscopic, or robotic. The current VTE prophylaxis strategies actually varies. In the world, we have the mechanical prophylaxis, which compression devices and early ambulation, pharmacological prophylaxis, low molecular weight heparin and direct oral anticoagulant, and IBC filters, which is in selected high-risk cases. In the last survey for a simple surgeon, that 97% use mechanical prophylaxis and 84% use combined mechanical and chemical prophylaxis. Of course, low molecular weight heparin is the most common used drug for chemoprophylaxis, but low molecular weight heparin has challenges of its own, that the patient compliance, especially long course, because low molecular weight heparin is daily injection, that some patient may found it discomfort, the economic burden in some countries that the drug and bariatric surgery does not covered by the insurance companies, so it becomes very expensive for the patient, and of course the risk of bleeding. And there is a very underestimated phenomenon that occurs with low molecular weight heparin, which is called reactive thrombosis. The incidence of reactive thrombosis is about 0.5%, which is actually the same incidence of portal vein thrombosis after bariatric surgery, even without using any chemoprophylaxis. And myself, I saw a lot of cases, not a lot of cases, number of cases that have portal vein thrombosis directly after they stop a low course of low molecular weight heparin. They stay for low molecular weight heparin post-operative for 1 week, maybe 10 days, and 2-3 days after they stop the molecular weight heparin, they present with acute abdomen and CT show portal vein thrombosis. The mechanism of reactive thrombosis may be rebound hypercoagulability, incomplete anticoagulation, underlying risk factors, and of course, the duration of therapy. Direct oral anticoagulant is approved for 2022 to use as a VTE prophylaxis. But there is some concern using direct oral anticoagulant in bariatric surgery. Gastrointestinal anatomy changes may affect drug absorption, limited evidence on post-operative pharmacokinetics. Key finding from the studies that rivaroxaban absorption is decreased after Roux-en-Y gastric bypass and remains therapeutic after a sleeve gastrectomy. Apixaban is least affected by Roux-en-Y gastric bypass and doesn't affect it by sleeve gastrectomy. But we still have some concern that alteration in gastrointestinal anatomy, physiology, and reduced gastric acidity, and maybe rapid weight loss alters drug distribution and renal and hepatic clearance. This raises doubts about their durability and reliability in the early post-operative phase. When we are comparing the direct oral anticoagulant and low molecular weight heparin as VTE prophylaxis post-operative, we have to talk about rivaroxaban and apixaban. Rivaroxaban actually, from different studies by Daniel Rodriguez and other studies, they show a very efficient VTE prophylaxis, which is very safe post-operative, with dose of 10 milligram, maybe 24-hour post-operative for 28 days following surgery with sleeve gastrectomy. A lot of studies, which is actually not very much in literature, maybe till now, I think I found searching the database 5 or 6 studies only reported the rivaroxaban use as a VTE prophylaxis after bariatric surgery. They report VTE incident. They didn't report any VTE incident, but what actually was a little high, maybe comparable with low molecular weight heparin, but a little bit higher, not significantly, but it's still present, that's the incidence of pre-bleeding after using rivaroxaban, especially in bypass cases. Myself, we published a case series 2024 that we used a rivaroxaban after as a VTE prophylaxis after Roux-en-Y gastric bypass, and we had an incidence of 7.6% of and we shifted to apixaban. Actually, apixaban results was more promising regarding cases. Is the voice clear? Is it okay now?
Yes, yes,
okay.
It is.
Okay, so regarding using apixaban in the literature, the studies reported a very low incidence of VTE was 0.5%, which was comparable to low molecular weight heparin. And in another study by Billy, they reported no VTE accident and in using apixaban, and both groups reported no bleeding, no significant bleeding after starting apixaban. Our center experience since maybe August 2023, we had more than 1,000 patients of different bariatric surgery, sleeve gastrectomy, Roux-en-Y, NGB, and reduced surgeries. And our protocol was starting at 2.5 milligrams, 3 days post-operative to 1 month post-operative, twice daily. We have no symptomatic VTE incident, and we have no clinically significant bleeding. And actually, this study is going to be published soon in obstetric surgery. So we recommended to use apixaban as a main VTE prophylaxis after bariatric surgery, as it better patient compliance, lower economic burden, and lower incidence of clinically significant bleeding. But still, there is some challenges that we have limited randomized controlled trials. We need for more evidence and monitoring protocols. The drawbacks is still the safety profile. While direct oral anticoagulant are generally considered safe, But the altered pharmacokinetics after bariatric surgery is still a big question. And we have no studies in the literature now that had a level A evidence in changing the concentration and plasma concentration after bariatric surgery, and whether it will affect the safety of the drugs. And we have, of course, the limited evidence on using oral anticoagulant after bariatric surgery is still in literature. Unpredictable absorption, we have a risk of underdosing and lack of monitoring tools for all the direct oral anticoagulants. So current evidence and recommendations, there is no level 1 evidence, either consensus of VTE chemoprophylaxis after bariatric surgery. Early mobilization and the mechanical prophylaxis is a must. Low molecular weight heparin is the standard worldwide, but avoid short courses and sudden cessation. Extended prophylaxis with apixaban, 2.5 milligram twice daily from starting post-operative day 3 till 1 month is highly recommended. Thank you.
So thank you very much for a really nice presentation and nice results. I would like to ask, do you have any control group? The one is receiving this perorally medication and the other one low molecular heparin?
No, we didn't use low molecular weight heparin. At the beginning, we used the low molecular weight heparin, but we're afraid of the bleeding, especially in bypass cases. In bypass cases, maybe 5 to 6%. After starting the low molecular weight heparin, we used to have the endoluminal bleeding. We shifted to rivaroxaban, and we compared rivaroxaban with low molecular weight heparin. And after that, we shifted to apixaban. And after we shifted to apixaban, we have a low incidence of endoluminal bleeding after bypass, and we start to use apixaban in bypass cases and sleeve gastrectomy cases for 3 years now.
Okay, so no low molecular heparin anymore.
No, we don't use them. We use the low molecular weight heparin, a single dose, 12-hour pre-operative, only single dose.
Okay, thank you.
With the permission, I would like to ask you and congratulate you for the presentation. I think this is a very interesting presentation due that it gives another way of thinking on bleeding, no? Which is something that is feared by our surgeons and ourselves every day. My question was, first, do you do any mechanical prophylaxis during the surgery and after very high mobilization of the patient to keep him during 3 days without any type of drugs? This for one question. And then the second, you showed us your results. Do you think there's still more margin to improve the results in more complex cases, maybe with this type of chemoprophylaxis? The treatment of
Actually, in answering the first question, in the first 3 days, we depend on early mobilization and the mechanical prophylaxis, the elastic bandage, and the intraoperative. We use the elastic bandage and the intermittent air devices to prevent any DVT intraoperative. And in the first 3 days, we depend on mechanical prophylaxis and good dehydration of the patient for fear of bleeding, of course, especially in bypass cases. And 72 hours after post-operative, we start using apixaban. We are using this protocol now in about 3 years, and we have no issues regarding bleeding. Maybe we have one case of bleeding in endoluminal bleeding before starting apixaban. But after starting apixaban, we face no endoluminal bleeding in bypass cases, especially. Your second question, in a very high BMI patient that maybe above 65, or patient with a history of DVT and pulmonary embolism, maybe we think we can raise the dose to 5 milligram twice daily. But if the patient had this dose recommended by his cardiologist, I asked the patient to continue on his prescribed dose. But if he stopped using the apixaban or any other oral anticoagulant, we continue by the same dose, 2.5%. And I think this kind of patient will be published separately, a paper for this high-risk patient according to our criteria, because I mentioned before that all our patients, according to Caprini score, at already a high-risk patient, but we have a very high-risk patient that we will put them in criteria with the high BMI, a history of the DVT.
Okay, thank you.
So,
Dr. Mohammed, congratulations for this important presentation and very nice study. In your series of over 1,000 patients, did you actively screen for portal vein thrombosis with imaging or only capture symptomatic cases?
We check our patients 3 times in the first month post-operative, and any symptomatic patient, we go for portal vein duplex. And we have but we don't do it as a routine post-operative investigation. We do it on selected patient. If the patient have any agonizing abdominal pain post-operative, of course, we have to do a portal vein duplex, and we have no portal vein thrombosis recorded. And another actually limitation of the study that we didn't study the silent DVT of the lower limb. I know this is another limitation, that some patient may have a silent DVT and they don't have any symptoms. We didn't check for this either.
yeah.
Thank you.
Thank you, Dr. Mohammed, for this illustrative presentation and nice study. We already had a similar study in our institute, but only in sleeve gastrectomy, because as we know that most of the wax are absorbed through the upper GI. So when you do bypass and you bypass this part of the GIT, so the absorption is to be checked. I know that apixaban is the least to be affected, but as you said, there is no level 1 evidence. But my question is about the high-risk patients. We know that most of bariatric patients are moderate or high risk according to Caprini score. I'm speaking about those with high BMI, those with previous DVT, and those with obstructive sleep apnea or varicose veins. Those are considered very high-risk patients of developing VTE. So do you still try to use the standard wax with the same dose, or you increase the dose, or you combine them with low molecular weight heparin, especially in the early post-operative period? And what about patients with intolerance to oral intake in general? Did you have any of them in your study? So they vomit, they threw up the tablets, or they all tolerated the oral intake? Thank you.
Thank you, Dr. George. Actually, we don't have patients who had this kind of pill intolerance. If the patient had intolerance to fluid, this patient have to be readmitted. And actually, if the patient is readmitted in the hospital and he has this kind of intolerance, he will be given a low molecular weight heparin as a prophylaxis. But in our study, in our center, and in our university, we faced in the last 4 years, maybe 6 or 7 cases of portal vein thrombosis after using low molecular weight heparin. All the patient had a short course low molecular weight heparin for 1 week, or maybe I saw a patient after 2 weeks of low molecular weight heparin, 3 days off, then patient presented with portal vein thrombosis. And among this 7 patients, we lost 3 out of massive resection. So actually, we become afraid of using low molecular weight heparin post-operative. Regarding the very high-risk group, if the cardiologist or the vascular surgeon of the patient recommended a higher dose, we are giving our patient a higher dose. But if their original physician doesn't recommend a special dose, we keep our dose the same, 2.5 twice daily.
Okay, thank you.
So, if no questions, I would like to thank all the moderators and presenters for really excellent presentations, and I would like to thank them for sharing with us really great ideas. And I hope we will meet next time again and give a word talk to Dr. Ariel Ortiz to close the webinar.
This has been an IBC Oxford University Hot Topics in Surgery production. I want to thank my co-chair, our moderators, and our distinguished panel of experts for their valuable time and talent today. We want to acknowledge all our partners and sponsors as our global collaboration produces safer and better outcomes. To view the complete Hot Topics in Surgery series, subscribe to our IBC YouTube channel and follow us on our social media platforms. And don't forget to mark your calendars as the 7th IBC University of Oxford World Congress is taking place 15th through the 17th of September of 2026 at the University of Oxford, UK. For more information, go to ibcclub.org. And now let's view another brief episode of IBC's exclusive Spotlight on Industry and today's sponsor. From IBC Global, stay safe and God bless.